Great. Welcome back after a little technical glitch. We're going back to Addie.
Thank you. Very glad to be here. Addie Strumolo, Acting Commissioner of the Department of Vermont Health Access. I was just going to spend a minute. I know you've heard from a number of my colleagues already from DEVA this session, but DEVA basically operates the Vermont Medicaid program. We serve as a health plan and administer that. We also are kind of the door into the public health care programs for the state of Vermont. So we operate the health insurance exchange known as Vermont Health Connect. So Medicaid, as I think you all know, is a federal state partnership program. So there are pretty strict federal rules that we have to follow in order to get federal funds to support Vermonters coming into our programs. So as I said, I'm currently the acting commissioner. My usual job is deputy commissioner, where I oversee that door, the eligibility and enrollment pieces for Vermont Medicaid. And I was going to make a few comments on the bill as a whole, and then, as the chair said, focus on the eligibility provision. So the sections that would change or study a change to the way people qualify for our programs. So I think where I wanted to start is to say that I see a lot of this bill as a vote of confidence in the Vermont Medicaid program, which is, I really appreciate that. I think it's been a turbulent few years with COVID, and I'm really hopeful and confident that we'll come out of the unwinding period that we're in, stronger than ever before, and look forward to talking with you all about what that process has looked like. But I think for that reason, it is a good moment to look at what the coverage options are for Vermonters. I don't think we disagree with that. And in particular, there's this dynamic between the Medicaid program and the marketplace of Vermont Health Connect and the subsidies that are available to people through that door that will change in a few years. So there's the enhanced subsidies that are in place through the end of 2025, and that expiration is looming large. So that's another reason why it's a good moment to look at the kind of the coverage map here in Vermont. And this bill, H721, would really stand to change that coverage map in Vermont, and that I think we would say requires some pretty careful consideration. This, I think, goes without saying, but none of the proposals that are in the bill, either coverage, eligibility, or rate, are in the governor's recommended budget. And many of them are likely to carry significant price tag, which will require some funding and prioritization, obviously. And so we would recommend careful, policy, technical, fiscal analysis, all of this before proceeding. And I would say that we want to be good partners and, help you with that process. But I'll just preview that I think we will likely need some additional resources in order to help with that. So now I'm going to start going through the sections that the chair named.
Can we just?
I'm happy to stop there.
Yeah, let's just stop there. Are there any questions? And make sure everyone understands the subsidies versus Leslie.
Just said something and you probably can't remember what it was. The last couple sentences you said about what you're going to have. You said that it's not in the governor's budget, requires capital planning.
Yep.
Could you expound beyond that? I missed it and I'm trying to get that.
Sure. With a proposal like this, we would just recommend a careful analysis that includes the policy pieces, the technical pieces, and the fiscal pieces, and put that in place. And I think for us to be able to help with that, we will need some additional resources.
Okay, that's what you said.
Yeah.
Thank you.
Leslie?
This went by fast, and you said something about some change in 25, and
Sure.
I'm not familiar with that, so I need to understand that, I guess.
Sure.
Or I missed it or whatever.
Yeah, thank you for asking that. So for Vermonters who aren't income eligible for Medicaid, they can enroll in the marketplace, and they can enroll in a qualified health plan. And at certain income levels, they can get subsidies to help with the costs of the qualified health plan. Those subsidies were established in the Affordable Care Act.
So that's what
way
you're talking
back.
about, the subsidies going away.
Exactly.
Got it.
And then the
Okay.
enhancement happened in the American Rescue Plan Act, and that's what's scheduled to expire at the end of 2025
Thank you.
And they are scheduled to expire unless action is taken by the federal government.
by Congress. That's right. Yeah, there's no administrative path to that. It has to be a congressional action to
Is that
extend.
on the docket at all? Federally?
My impression is that is probably caught up in the federal election and probably won't.
Delete.
It's out of my wheelhouse.
All right, are we good? Can we proceed to section 3? Okay.
Great. Okay, so section 3 obviously has two parts. One would be expanding income eligibility for Medicaid for adults over a period of time. And the other is expanding the group who can access our Dr. D program, Dr. Dinosaur, which already has higher income limits, and making that available to more people. In both cases, those expansions exceed federally established income limits for Medicaid. So as you know, we would be talking about the state fully paying for that expansion unless the federal government were to give us permission for such an expansion. And there is a path for getting that permission that I'll talk about, but I just wanted to make clear that this is, again, we want to be talking about this in partnership with the federal government so that the state doesn't have to carry the full cost of an expansion. The path for getting that approval is called a demonstration waiver. You might have heard this referred to as an 1115 waiver. And it basically allows states to apply to waive certain provisions of federal law in order to test kind of more innovative ways to deliver and pay for healthcare services on the state level. Vermont has done this. Most of our Vermont Medicaid program is established through a demonstration waiver called the Global Commitment Waiver that I think this committee has heard about. We recently renegotiated that waiver for a period of 5 years.
When's the 5 years up?
Because I knew you were going to ask that. I think 2027.
Okay, thanks.
We might need to double check.
I should be on this, I'll send.
Okay, great, thank you.
So the proposed expansion in section 3 would require a waiver, potentially multiple waivers. And it's, I would say, unclear what the federal appetite would be for this at this point. Because as I mentioned, it would represent a pretty fundamental shift in the coverage map for Vermont. It's a different vision than the Affordable Care Act, which essentially kind of ends Medicaid at 133 or 138% of FPL. And then leaves it to the marketplace and the subsidies to kind of carry on coverage for that higher income population. I totally recognize that this bill represents an interest in looking again at that structure. But the current Medicaid waiver for Vermont already pays for state subsidies for that income group that is above the current Medicaid income limits, up to 300% of FPL anyway. And so given that the waiver has that in place, it would definitely need to be a federal conversation about what the change would be.
So I just want to ask a question.
Yeah, sure.
So the subsidies that are available to that population cover premiums.
Right.
And so there's still the cost shared, potentially a high deductible that is still falling on the Vermonter who has that coverage, correct?
That's right.
Okay.
There are subsidies for cost sharing also, but the one that is established in the waiver is specific to premiums.
So a subsidy can bring down the cost of the premium to maybe a manageable amount, but then a lot of people are still underinsured because they don't have the money to get to the deductible that would then cover.
That's right. Yeah, and I think my point there is just that because that subsidy exists in the context of this waiver, which covers our Vermont Medicaid program, if we were going to go in and ask to actually expand Medicaid to cover that same population, we would need to get permission to do that.
All right, and then Alyssa.
Yeah, and it kind of piggybacks on what Lori just said. Do we right now pay a piece of the subsidy, or is it all fed?
No, we do pay for some of it.
So we're right now subsidizing folks in the percentage levels that we're trying to now give them
That's right.
free premiums. Okay, so, all right, so we presently pay in conjunction with the feds for those subsidies. And now they'll disappear and we will pick up all of it.
No, the idea would be to change, I mean, we're getting a little bit down the road here, but
Yeah,
I think
right.
the idea would be to explore a demonstration waiver where instead of
Right.
having subsidies for that population,
Yeah.
we would have full Medicaid for that population.
Right,
It would
okay.
be paid for by both parties, both the
Okay,
federal
it'd still,
government and the
it'd
state.
still be paid for by both, but they would get, instead of paying a piece of it, there would be no piece to pay, we would pay for all of it.
Yeah, I mean, that gets at a section later in this bill, but from the member's perspective, Vermont Medicaid in its current form has much less cost sharing than insurance plan does.
Okay, thank you.
Just on the same topic. So currently, up to you said 300% of FPL.
Or BPA,
We
The
subsidize
VPA is.
Vermont Premium Assistance.
Vermont Premium Assistance, so we subsidize, and then they also get the federal subsidy as well.
Right.
Okay, so, I mean, I know you probably don't have an exact number, but let's say I'm at 299% of federal poverty level. Can you kind of give me an idea of how much somebody would be paying on the exchange for their, like, a monthly cost, like the silver?
I'd be happy to come up with some examples. I don't think I'm going to be able to do it off the top of my head, but
Are we talking $500 we're paying, or are we talking $50? I mean, is there?
it really depends on what plan they choose. But at the silver level, there are robust subsidies both for cost sharing and for premiums. So I think, again, I don't want to throw something out there, but I think in that kind of middle range, you could be paying, half of what the premium is on the open market, essentially.
Yes.
Yep, but I want to go back to, subsidies could potentially be ending in 2026, right?
Yeah, at the end of.
At the end of
25.
25. And although we've had the subsidies, which have been wonderful for Vermonters, I don't want to say they're not. I think there is a lack of, for some people aren't realizing they can get those subsidies. And then also, we still have that high deductible cost sharing piece of it. So people are underinsured. And that percentage, we know through the Vermont Health Insurance, Household Insurance Report, whatever it's called, is increasing. That percentage is increasing, where they're estimating now about 40% of Vermonters are underinsured. So, Art, and then we'll keep going.
When the Fed subsidy ends, like Lori said, at the end of 25, does the state subsidy automatically end too?
No, the state subsidy is just in statute, so it doesn't have an expiration
so-
date.
We've had it.
All right, so we are still subsidized, no matter what 25 is, we're gonna be still subsidized.
Right, yes, and so.
Not as well.
Not as well, yeah, and maybe what we
I get
can
it.
do is come back at some point and talk about the
Yeah.
subsidies again. We've had that presentation before, but it would be.
Sure, yeah, and we could give some examples of
Yeah,
the
yeah.
impact that
Thank
they
you.
have had.
Right.
But yeah, the Vermont Premium Assistance is also in our demonstration waiver with the federal government, so that is, subject to negotiation. Okay, so I was gonna move on to kind of, we have this question around feasibility and working with the federal government on an expansion. Inherent in that is also the fiscal analysis. We could calculate the cost of covering, additional Vermonters, the ones who are currently in the marketplace at those income levels. But we would want to account for a conversation around federal funding for that population. It's unclear what that, match would look like. And then dynamics with the existing funded programs like being Vermont Premium Assistance. And then there would be the conversation around who from outside of the exchange would come in to, a larger Medicaid program. And I think all of this, it's a complicated analysis. And so we would benefit from technical and probably actuarial support in looking at that. And then even once we have kind of a clear path to having this federal conversation, there would be, state considerations for implementation, like rulemaking, IT changes, operational readiness, and frankly, kind of a cultural shift in talking about Medicaid as a broader program than it is now. So all this to say, there's an effective date in this bill, which is not workable in terms of the January 1st, 2025. So I just wanted to flag that. Overall, our recommendation would be to take some time to study this and explore feasibility. And we're, again, happy to work with you on that, but we'll need some additional resources.
Great, and I do think we'll be talking about a section that has some resources in it already that we can see if we can do something there. Okay.
Sounds great. And then the last thing I wanted to flag within section 3, which is significant, is that there are pieces within this proposal for expansion that could be more viable and not require the demonstration conversation. In particular, Dr. Dinosaur for pregnant individuals and potentially an incremental expansion for children up to age 21. It looks like those could be pursued through what's called a state plan amendment as opposed to a demonstration waiver. We would still, there's a lot to figure out there still, but it could be a path to doing something sooner than opening up the larger waiver for the big expansion. So I think we would recommend doing fiscal estimates on those two populations, and then having a conversation about a timeline for implementation and support for that.
Is our FMAP different for children? I can't remember.
Yeah, the FMAP is different.
Is it more or less?
Chip, which is like 70-30. The rest we got your dinosaurs on the regular.
Okay, so if we expand it up to 21, would we get the FMAP under chip or would we get the regular old FMAP?
If we get met, if we met,
Please.
for the record, no one
Thank
wants
you.
to fill out. If we were to get FMAP at all, probably regular.
Thanks, sorry.
Sorry, I didn't.
No, I think that's one of the big things that we would have to figure out is what the federal match would look like.
And so that could be a separate fiscal estimate from you all, separate from what you would need for the rest of the section 3.
That's right.
Okay, great,
I think we could put that together for you, and would be happy to.
great, thank you.
Okay, so I was going to move on to section 8, which is IHEP, but are there any more questions on the broad expansion provisions in section 3? Good, great. Okay.
And if you can describe IHIP, sure, that would be helpful.
Yeah, so IHIP is the Immigrant Health Insurance Program. And, you all passed this a few years back. It's a Dr. Dinosaur-like program for children and pregnant individuals who don't qualify for Medicaid based on their immigration status. So we've had this program in place for a couple of years. I think it's been, successful in filling a coverage gap. So we're, supportive of looking at that and thinking about whether there are some enhancements there. It's a fully state-funded program, so it's not Medicaid, even though it looks like Medicaid. So we don't need to have that federal conversation. And I think there are a few technical things that we would need to understand a bit better about this proposal before giving you a fiscal estimate and a proposed timeline for implementation. This gets a little bit complicated, but with immigration status, there's something called a 5-year bar in Medicaid. So certain folks who are kind of blocked from enrolling in Medicaid due to their immigration status have to just wait 5 years and then they can enroll in Medicaid. During that time, they can enroll in a qualified health plan and get subsidies. So this didn't apply to the current population that's covered by the IHIP program, but with the expansion, we would have to understand whether you're looking to include people who are subject to this 5-year bar, and it would really apply to the 21 to 26 age range that's envisioned in this bill.
Why might there be a 5-year bar on someone? Like what type of immigration status would they have that would make a 5-year bar?
I am not an immigration expert, but my kind of general understanding is that it has to do with timing. So if you achieved a certain immigration status, there is a law that says you have to wait for 5 years before you can enroll in a benefit program that's funded by the federal government. I'm happy to get back to you on what the specific statuses are.
That'd be helpful. Thank you.
Okay.
If we do that with the immigration status, is there any type of identification they have to come up with or just anybody?
So once we have clarity on what we'd be looking for this program, we have a basic verification process that would ask people to put information on their application so we can say, okay, yep, you're in the right category, you can sign up. It's pretty streamlined at the moment, but yeah, we would, in our implementation conversation, we would look at what that actually entails.
And I guess my other question is, what's the difference between Dr. Dinosaur or that they're not qualified for 5 years is a qualified health plan?
What's the difference?
Yeah, they're eligible to go onto the qualified health plan. So what is that different than signing up for Medicaid?
It's just different rules. So for some reason, the federal government decided that they wouldn't have the 5-year bar in place for the federal subsidy programs that are applicable to qualified health plans. But just to kind of get down to basics, I think what we're talking about here is we just want to understand if this is proposed to be a gap for people who don't have other coverage options, or if this is meant to be another option for people who also have access to the exchange. That would be the question that we're asking. I think based on conversations last session around expanding IHIP, I think the vision was around trying to fill a gap in coverage for people who don't have other options. And we'd be happy to propose some language to get at that here, but I don't want to make assumptions.
So let's flush this out. So the folks who don't have access today because of their immigration status and have the correct, whatever it is, immigration status, could go onto the qualified health plans and get subsidies. Just like other people, just like everyone today. But part of our reason for me, who sponsored the bill, I'll just say, is that we were looking at the underinsured market. So they can go in and get subsidies, but they could still be underinsured. If, though, we allow Medicaid to sign up for Medicaid, it would be a larger cost to the state because it is fully state funded. And that would preclude them from just going to the QHP, like they could only do one or the other if we did this.
So it's a little complicated because this is not Medicaid. It's
Right.
this kind of state specific program.
Right.
Normally you can't get the subsidies if you have access to another form of coverage.
Right.
This, I think, would be a bit groundbreaking in terms of it being a state only program. But under federal rules, you can't get the subsidies if you have access to minimum essential coverage. And I think it would be hard to argue that IHIP isn't that. This is getting a little technical, for which I apologize, but I think that dynamic between the two programs is one we'd really have to sort through to understand what this expansion of IHIP would look like.
Okay. Art, and then Alyssa.
Yeah, IHIP and Dr. Dinosaur, they're totally funded by the state.
IHIP is.
IHIP is.
Yes, we used to call it Dr. Dinosaur Light
Right,
coverage.
I remember that, yeah.
But no, the immigrant program is funded by the state.
Okay,
And Dr. Dinosaur is federal and state.
okay, it's the same match as Medicaid, Dr. Dinosaur? I've never really understood it, that's why I'm asking. the
There are a range of different what's called federal medical assistance percentage,
Gotcha.
depending on the population. We could probably
No,
give you a
all right.
table, or Nolan could.
Okay, I get it. I just want to get a general
Yeah.
overview. Yeah, okay.
Alyssa?
I'm just trying to understand this. So there's a federal law that you cannot have any benefits that rely on federal monies for 5 years. But that's if you have, if you have a legal immigration status? So isn't this really feeling just like with IHIP, which is, do people who have no legal status, do they have to have that 5-year? Because they shouldn't have any restrictions because they're technically like not even.
So there are definitely no restrictions for IHIP. And what I would say is, I think traditionally the plan that has been available to that population is buying a full cost qualified health care, which is, not ideal. So I think all we're wondering is if the spirit of this bill is to fill a gap for someone who has no other options, or if it's to give a new and potentially better option to someone who could enroll through the exchange.
Okay. All right, I understand. I guess when I was reading it, I was thinking that it was just for people who have no other option.
So that, I'd say we'll talk about that as a committee and get back to you if that's okay.
Yeah, that's how
I would want you to look at. Art,
Yeah, the only change I see in section 8 is the age change.
right.
Any idea how many this will 7 years of life that we will gather in that? How many other effects? Probably not.
No, because these are folks who don't have,
Right,
coverage.
gotcha. All right.
But I think that's what we would look into, and we did it, when we were standing up IHIP to begin with, so that would be the next step. And I would just offer, I think that if the decision is to allow folks to enroll who do have access to the exchange, there is a level of complexity there in terms of the application process that we would have to think about. Just throwing that out there.
Do people that, right now, you could be on your parents' insurance till you're 26. Will they have the option of saying, okay, you're on your own now? Because you will not meet the federal poverty level? Will they have a choice to do this?
Under the proposed
Yeah.
expansion in IHIP or?
Well, either one. If I have a child, 25 years old, they're under my plan. If I say, hey, I can save some money by dropping
Oh, I
you
see what
off
you're
my
saying.
plan, and you're eligible to sign up for this because of your poverty level percentage, can they switch over?
I think that's exactly what we would want to explore around the Medicaid expansion. But
And
theoretically, yes.
And so correct me if I'm wrong too, so how it would work today, if you're a family of three, and as a family, your income level is 200% of the federal poverty level. As a family, you are not eligible for Medicaid insurance.
Right.
But as a child, you are eligible because you're below the 317. So my husband and I could say, well, we're going to buy a QHP plan and our son is going to be on Medicaid. And Medicaid today stops that at 19.
Oh, okay.
So only commercial insurance goes to 26. And so part of this bill, not the IHIP, well, the IHIP piece too, but says we want to be able to say to those 19-year-olds, you can stay on until you're 26. And so that would just be an extension of what they're doing today. But as Addie had said earlier, there are, we have to look at that and the impact, and then one would be potentially a state plan amendment versus one we'd have to negotiate further in a demonstration. So that's the difference. But the 26 is only for commercial insurance.
Right.
Did I say that right?
Yeah, definitely. The only thing I would add, and just to underscore this dynamic with the subsidies, is that if a child is on a parent's plan through the qualified health plan marketplace and getting subsidies, you cannot get subsidies if you have access to Medicaid. So that's a dynamic that that's what I meant by we'd have to understand these various funded programs and how they would work together with the expansion.
So I just want to clarify that. So if you're eligible for Medicaid, that needs to be the option you take. You can't say, I want to get a qualified health plan and get subsidies
You can only get it at full cost.
at full cost. So I think that's what we'll work to know. Okay, great. All right, so we will get back to you on the section 8. Okay, great.
I wasn't going to spend a lot of time on section 9 because I know you're having kind of ongoing testimony around that. This is the Medicare Savings Program. But just to say, we definitely appreciate the affordability issues with this population and are working on that fiscal analysis. So the remaining sections are studies, 11, 12, and 14, which we're, very much open to, and might suggest essentially combining, since we are, talking about wanting to study the Medicaid expansion. The first one is around a public option or a buy-in option for higher earning small business employees, which is, an interesting concept that's been floating around for several years. And I think it does beg a question around what if we're going to allow a space for small business employees to buy in, is there also a space for individuals to buy in at higher income levels? But, we don't oppose looking into that further. Section 12 is about cost sharing for the Medicaid expansion. And I think this makes sense to look at in context of the broader analysis. We assume that cost sharing in this context includes premium, so the amount you pay, on a monthly basis, because the co-payments, which is the other form of cost sharing in Medicaid right now, are already very low. And this proposal would cap them at current levels, the, highest of which is $3.
I thought that this was the start of something really good here, in terms of the way I look at this thing. But tell me, would this study, because it's a study, we probably don't have all the things, all our ducks in a row with it, but would it mean that people presently on Medicaid and at the lowest rung of economic status, at the federal poverty level, would everybody be responsible for a little bit of skin in the game, a little bit of money each month, all the way up and graduated up and maybe as a percentage of their income? Is that kind of the thought process?
I mean, I think I would defer to the sponsors on that, but
Yeah.
I think that we have very, very minimal cost sharing in Medicaid right now. Premiums, as a side note, premiums, which are only for certain populations within Dr. Dinosaur, have been suspended for a long time now because of COVID and will be for a while. So we just have this kind of modest copayment for a few different scenarios, and the biggest one is $3. So that's the current lay of the land. I mean, I'm guessing the idea here is to look at what it should look like at the slightly higher income levels
Right,
to
okay.
have some
We
member
can
responsibility.
Gradually,
I can answer that from the sponsor level.
yeah.
So my thought was that we would leave everything as it is for Medicaid that's in place today, up to 133%. But should we expand it, is there some type of, I'm going to say the word cost sharing, but as you increase your income levels and have access to Medicaid, should there be some level of premiums that you have to pay? So yeah, it's getting to that point, but the intent is for Medicaid as it is today to stay as it is today.
I would suggest to you, if we're gonna do a study on this, that you look at everybody having a little bit of skin in the game, from the lowest income person to the person on the edge of where you want to set this thing. Because if everybody had skin in the game, I think it would change things a little bit. I think it would change how much money this would cost, and it would, I think, give people a sense of that, your healthcare isn't free.
Addie, is the cost sharing that's in place today, or I'm sorry if I'm not using the right terminology, for Medicaid set by the federal government or the state?
State.
The state, okay.
But
Yep.
The last thing I wanted to flag on this section is that there's also a federal law that caps cost sharing in Medicaid at 5% of household income. It doesn't happen very often right now, given our kind of limited cost sharing that we have, but that is a provision that would be worth considering as you explore this
So
further.
capped cost sharing at 5% of income. So I get, for my benefit, maybe you have figured this out, the cost. So when we say cost sharing versus premium versus, so can you just describe all those?
Yeah, I think cost sharing is the overarching term. And then within that, at least in this context, we're talking about premiums, which are monthly out-of-pocket fees for the coverage. And then co-payments, which go with certain services like prescriptions or outpatient hospitalizations.
Federal cap, copay and premium.
It is.
Point.
Yeah,
And deductibles.
right. So in the insurance world, there are other forms of cost sharing like
Not in
deductibles.
Medicaid.
That's right.
Okay, got it.
It's premium and co-payments.
No deductibles in that world.
yeah.
That's right.
Okay, great, thank you.
So the last section I was going to cover is the market structure analysis in section 14. And this is the one where I kind of started this way. I think this is a really important conversation. We have this expiration kind of looming ahead of us. And this is a piece that we should look at, the structure, and it feels like it could dovetail with other mechanisms to address affordability for people who might be impacted by this potential expiration of subsidies. So we might suggest broadening the language a bit, but it's timely and we would definitely support it and also appreciate the recognition that there would be some cost associated with it. So I think we can talk more about exactly how to do this, but it could be a way to kind of combine in the expansion study as well.
So if everyone remembered, I apologize, I don't remember who was on the committee at the time, but remember we had to decide, so the federal government put the subsidies in and then they were gonna expire, and so we had to decide if we re-merge the markets, or, so we have I know Melanie wasn't here, so I'm looking at Melanie.
Before, yeah.
And I don't know, so it was individual, small business, you were here, right? So do we re-merge them, separate them, and
I
so
did that over Zoom.
we did that over Zoom, that very, and then we did it again, so we done it twice.
Correct.
Right. So now with potentially them going away, we have to have that conversation again. And I would say if they go away, it really is going to hurt Vermonters. People are really relying on these subsidies from the federal government to pay for their healthcare. So that's the reason I put that in, knowing we would have to have this conversation again anyway, and let's get a start on it and make sure Diva has time to do the analysis. So any questions on that? So I would say, if you could come, I like the idea of in that section to include all the analysis that has to be done for the bill. So if you could come back with some language suggestions, and if 250 is the right number or not the right number, what the right number might be, that would be helpful.
Sure thing. Happy to do that.
I think that was all the sections you were going to do. So are there any additional questions for Diva? Thoughts or comments? Great. Oh, listen. Always one at the end.
I'm just thinking about like a larger vision of Medicaid. First of all, I think it's a very well-run program. You started by saying that gives you the confidence to know that you're doing a great job, and I think it is. It's a great program. Do you think there's the capacity at the state level to actually be able to implement these expansions? And I'm not talking about the money aspect. I'm not talking even about the workforce, the state employees. Do you think there's just sort of the capacity for Diva to be able to become a larger entity than what they are now?
Thank you. That's a really good question. I think there's two pieces. Maybe I'll just address, you started with the vision, and maybe I'll just say briefly, I think that the vision for Vermont Medicaid is in our current global commitment waiver. That's, pretty recently negotiated and kind of represents, where the administration is in terms of Vermont Medicaid. To the extent there's traction and passage of a broader vision for Vermont Medicaid, I do think there's capacity in Diva. I think that actually these types of changes around just FPL levels aren't that hard to implement. And I think it would be more, just doing more of what we're already doing. I think there are certain things that are really fundamental changes, like allowing for a buy-in option, that would be much more difficult for us to undertake. That really would be kind of a big shift in the work that we're doing. But just making what we already have available to more people, in and of itself, I think there is capacity for that, but that's separate from the vision.
Question, Mari?
I have a vision question and a conceptual question. So I understand it may be putting me on the spot a little bit, and feel free to do whatever you need to do about that. I'm
Meaning not answer.
Yeah.
Not appropriate.
It's about pharmacy and the concept of being able, at some point in the future, to have Vermont have a process where it's the state, some entity in the state, a pharmacy board, something, is able to be its own wholesaler and try to reduce the cost of prescription drugs. In a 50,000 foot view, do you see that uh, like Vermont having the capacity for that starting with Medicaid.
I will have a tough time answering that, not because of the kind of, vision piece, but mostly because I just don't know very much about that at all. And I would maybe defer to some of my clinical colleagues. I think just on its face, it sounds like a pretty fundamental shift. So with anything new, there would be a lot to explore.
Yeah. Okay,
So,
planting seeds maybe.
okay, thank you.
Thanks. Any other questions about 721? Great, thank you very much. Appreciate your time and good to see you in person again.
Plus.
All right, we have Mary Kate Molman from Bi-State on Zoom, I think. Mary Kate, are you there? Good morning.
Good morning. Hi. Thank you. So I will be fairly brief on the eligibility. For the record, my name is Mary Kate Molman, Director of Vermont Public Policy for Bi-State Primary Care Association. And I am sorry I'm not able to be there in person. I am home with a sick kid who was unexpected. So first on the eligibility point, Bi-State Primary Care Association represents our federally qualified health centers in Vermont, the Vermont Free and Referral Clinics, and Planned Parenthood of Northern New England. And generally, our members are supportive of any measure that expands access and reduces burden or barriers for people to seek care. So this could be financial barriers, cost sharing, et cetera. So anything that allows, takes one thing away from people who may be hesitant to get care and put off care because of financial burdens. We are supportive of measures that reduce those barriers. I would point out that Bi-State's vision and mission, where our vision is healthy individuals, families, and communities with equitable and quality healthcare for all. And our mission is to advance access to comprehensive primary care services for all, with a special emphasis on New Hampshire and Vermont. And obviously with you guys, it's Vermont. And H721, especially the eligibility provisions, do closely align with these goals. And they also align with our members' mission to provide the care their patients need and to minimize the barriers for care their patients experience. So it would support our members in their ability to meet translation needs, increase access to nutritious food, and improve care management across community services, all of which have been pointed out to as priorities for the state in terms of where we want to go with primary care and reducing potentially avoidable utilization. So that's all I have on the eligibility provisions, and I can stick around for the payment provisions, but I can also answer questions.
Thank you, Mary Kate. So to summarize, in regards to the eligibility sections, Bi-State is in support of the bill. Is that a yes? No?
Yes.
Yes. Okay, great. Thanks. Any questions for Mary Kate? Okay, great. Thank you.
All right, thank you.
And we'll come back on the reimbursement rates piece. Sarah? Welcome.
Okay.
Good morning, everyone. Sarah Teachout with Blue Cross and Blue Shield of Vermont. Here to talk about your H721, the Medicaid expansion bill. Just high level, Blue Cross Vermont supports access to high quality health care through the expansion of health insurance coverage. And this bill contains a host of provisions that would impact health insurance coverage here in Vermont and the commercial marketplace. So to talk first about Medicaid expansion, there's three significant pieces of the Medicaid expansion in the bill, extending it from the ages of 18 to 26 for people who are pregnant, along with the phased in expansion of Medicaid eligibility to 312% of the federal poverty level by 2030. The numbers of people impacted by the first two provisions is likely to be fairly small. We clearly don't know the exact impact of the risk, but it's likely to be minor in the big picture. And so Blue Cross understands that and would support those provisions. Increasing the income eligibility, however, will shift a large number of people from the exchange marketplace to Medicaid. So that's where we have more concerns and quite honestly don't understand the full impact. Vermont Medicaid already covers approximately a third of Vermonters. Another third are covered by Medicare. And so there's only a third or a little bit less covered by commercial health insurance. Vermonters with commercial health insurance pay the highest rates to our providers for the exact same care that people on government insurance have. This exacerbates the affordability and the premiums in the commercial insurance marketplace for the dwindling population that remains covered under commercial health insurance. We do support increasing the Medicaid payments to 125% in that section of the bill. I can't remember exactly where it is. That would help address some of that problem. But shifting more Vermonters to Medicaid may lower the costs borne by one subset of Vermonters in exchange for increasing them for the remaining people on the commercial marketplace. And we can't evaluate the full impact there. So we would really want to look at the, study the impact. Another concern that we have that I think would be taken care of in a study is the proposal to move to 312% would certainly cover all Vermonters who currently qualified for cost sharing reductions under the federal ACA. So that's, I don't know if you want to get into it, but it's one of the benefits under the ACA. So all those people would be covered by the new, once you get to the top. Those are the exact benefits and the people we use to silver load on the ACA. So if you remove all the people who qualify for the CSR program, I don't believe we'd be allowed to silver load anymore. So it's shifting again, who's paying and who's benefiting from the federal dollars. We have a lot of questions about whether that drawdown of federal funds to pay for silver loading would be offset by shifting these people to Medicaid and the different sort of arrangements with the federal government there. So questions on that. There are 2 actuarial studies already proposed in the bill. You have one for the public option for the small group report, and then you have the second one on the merged market report. I think all of these things should probably be looked at together and not separate. They're all very, very interrelated, as you know. As far as the merged market report goes, we continue to be very concerned that Congress has not extended the expanded advanced premium tax credits that so many Vermonters rely on to purchase health insurance. So that is a huge problem. And we recognize that nobody really knows where that is going forward. And then I guess I would just jump to the Medicaid savings program in Section 9. We fully support the expansion of that program to protect low-income older Vermonters from losing health care benefits when they turn 65. Many people think that when they go onto Medicare, the government will fully fund their healthcare coverage, and that their out-of-pocket costs will go down. But between premiums for Part D coverage, deductibles, and the 20% cost sharing for inpatient stays, many Vermonters find that their costs actually go up significantly as they are no longer eligible for state and federal programs available through the Affordable Care Act. So to ensure that older Vermonters can pay for the care they need, we do support the proposal to expand the Medicare savings. That is our testimony.
We have questions, Alyssa. So specifically in the age group 19 to 26, do you have any numbers on, I realize most of your members in that age range are probably under still a parent's, but do you have any numbers on who in that age range has actually purchased individual coverage through the exchange?
I can ask. I think you get better information from DVA because they would know for all health insurers, not just Blue Cross. And I'm remembering back a couple years. It's been a while, but there was I don't see Addie.
I was gonna say, and
Addie knows the answer to that question more thoroughly than we do. There was discussion, and it was when the committee was still over there across the hall, where you talked about the highest rates of under insurance or no insurance coverage are for young people in Vermont. That's because we have community rating. So our insurance is relatively high for people in the young age brackets and relatively low for people who are older. So I think it is an area where people are not getting the coverage they need,
Yeah,
for sure.
yeah. So Alex, we're going to ask this question again because I think it's more for Diva. So you can take note of it. What's the question?
How many age 19 to 26 individuals actually purchase on the exchange an individual plan?
Yeah, absolutely. For the record, Alex McCracken, Department of Vermont Health Access. I don't have an answer for you off the top of my head, but we can get that.
Thanks.
Now, please, you see.
Okay, so I just want to make sure I captured this right. So Blue Cross Blue Shield would not be opposed to the expansion of Dr. D and the pregnant individuals. Lots of concerns around increasing the income level to 317, which
I think questions, really?
yeah, which I get.
I don't know if we understand enough the impacts.
Right. Support, you do support increasing the reimbursement rates for Medicaid. And you are also concerned about the merge market, so appreciate the study that's in here. And then fully support of the expansion of the Medicare Savings Program. Okay.
Yeah, and I think the one thing to say is that these studies aren't really separate.
Right, they're not.
One-
So
one
I
big
don't know if you were in the room, we've talked to
Wasn't.
Diva, so that's fine. We talked to Addie, acting commissioner, and so she's gonna provide some language to bring the studies together.
Okay.
And there would be a cost for this, they would hire someone to do the work, so once we get that language, we'll run it by the insurance companies, MVP hasn't testified, but we'll run it by the insurance companies to make sure that the questions you have would be part of that study. Okay.
Work with her on that.
Any other questions for
I don't
Melanie?
know, this is an appropriate question for now, so feel free to strike it if it's not, but I appreciated you speaking to the third of Vermonters that are on commercial insurance, and we all are understanding that when the subsidies end in 2025, it's going to be an enormous impact for affordability. Curious, as Blue Cross Blue Shield is looking ahead, are you anticipating making any rate changes or plans for how to help with that? If you don't do this?
Right. I think as an organization, and we are working with our federal partners to try and lobby in Congress to extend the tax credits. That's our sort of number one approach. Premium rates are set based on the price of care, has nothing to do with the amount of tax credits that people receive. So we can't adjust premiums just because people aren't going to receive as much in federal subsidies.
Which is really why we're all concerned about.
Yeah.
We're very concerned. We share your concerns.
No, I was curious, yeah.
Leslie?
So you heard about the premiums that people on Medicaid have to pay, which are pretty minimal. Could you contrast that with what people, I mean, I know they're different plans, but in general, people are paying in commercial role?
I am happy to provide the sheet with the premiums for all of our different plans. And I would also just caveat that with some people receive sizable government subsidies to help them pay those premiums. So it really depends on who you are and what your situation.
Help them play the premiums, but not the deductible.
Yeah, so apples to apples. I'm trying
Unless
to get
you're-
apples to apples here in this.
It's really hard to get apples to apples. So
I appreciate you wanting that. The one thing I would say is that the CSR program, it's cost sharing reduction is what that stands for, is intended to help people with their out-of-pocket costs by bumping them up to a more generous plan. So it doesn't solve the problem entirely, but that's what it's supposed to do. We also have a state CSR program that I think is essentially obsolete because of the level of the federal subsidies at this point. I think we also need to consider what we're doing with that program.
Exactly, which would be all part of the study. And I just want to keep going back to the fact that there's great support both at the state level and the federal level with the insurance companies, silver loading. We've done a lot of good work in this committee, but we still see the underinsured number increasing. So something's not working, and that's, this is a potential path forward after a lot of study to see what we could do.
Sarah, I just ask, I'm not familiar with the silver loading thing and I missed.
Oh, that's, yeah. We're not gonna do that right now. We can come back to it. That's a, unless you can summarize it really well.
And I don't want to take time. It's a concept that I've missed somewhere along the way.
Yeah, I don't remember, when did we do that?
We have talked about it.
Fisher loves to talk about.
Yeah, we can have Mike Fisher come in and talk.
18 maybe?
Yeah, it was before me, I think, and yeah.
Yeah, it might have been early on.
I wasn't, I came in 21.
I have a question. So when we talk about the population that buys a qualified health plan, so what happens when a business, I guess, let me phrase it this way. Could this happen or has this happened where a business has, they don't offer health insurance, so people buy on the qualified health plan, but then they decide to self-fund and that draws them out of the qualified health plan. Does that happen today? Or are we looking more at the larger corporations are the ones that self-fund and they were never in the qualified health plan?
I think it's all of the above.
Okay.
There's a lot of movement in the commercial health insurance marketplace.
So
It is both small and large companies. There's a really interesting study that I just saw, I don't know, Becker's or somewhere, talking about the percentage of the commercial marketplace that is self-funded, and Vermont has one of the highest rates in the country.
So we're already drawing people away from the QHPs. And this could be one more draw away from the QHPs, but
But when they go to self-funded, they're still paying the commercial rates to the providers.
I understand that.
They're not paying government rates.
But they're not part of the pool that sets the rates for the qualified health plans.
Right, and our concern isn't as much about the risk. There's a lot of movement in the risk. Our concern really is about the shifting of costs over onto commercial payers.
Okay, got it. So if we increase the reimbursement rates to an appropriate level, even though we're pulling people out of the QHP,
That will
that
help.
might be acceptable.
That will help.
Okay.
How much, may I ask, it has to do with the population involved, because that's a relatively healthy population that would be removing from your pool.
So the young people definitely, pregnancy is tiny. So I don't know the demographics of people up to 312%. I think that's what a study would tell us.
Great. All right, any other questions for Sarah? Thank you so much. Alex, if you don't mind, one question I forgot to ask Addie was when she suggests language for the study, if she could also suggest effective dates.
I will ask her.
Thank
Yeah,
you.
we'll work on that.
That would be helpful. Okay, so we're gonna go to sections 5, 6, and 13 at 10:30. And so why don't we take a break and come back to be on time for 10:30?